These measures are very important, which have to be followed in all cases of STDs. Privacy and confidentiality is the utmost importance. NMC says that all STI patients should be examined separately. There should be a separate room for the examination of all STI patients. We should provide them a comfortable environment. We should be non-judgmental and we should have professional attitude so that patient feels just like we are treating a sore throat or any other condition. Good morning, all the respected delegates, faculties. I want to thank the organizers for giving me an opportunity to share whatever little information I have on this such a big public health problem, which is also very important for sexual health. Now the topics that we will cover in this presentation, major clinical features. I will not go very deep into the clinical features. Investigations, Pankaj sir has explained investigations in a very good way, in very detail. I'll just explain what is important for the management. We'll go mainly into the treatment based on NACO and CDC guidelines and the general measures which are required for the treatment of these patients, and very importantly, syndromic approach, because our government is very much emphasizing on that. So STIs can be multiple: bacterial, viral, miscellaneous, or STD-associated syndrome. 20-25 years back, we saw that bacterial STDs like syphilis, chancroid, gonorrhea, they were very common, but now they have taken a back seat. Now we see viral STDs like herpes, anogenital warts, and molluscum. Most of the patients come with these problems nowadays. So first we'll come to herpes. Herpes, it's an infection caused by HSV1 and 2. HSV2 is more severe and more common in genital infections. Incubation period is 2 to 12 days. Once a person is infected, the virus remains dormant in the sacral dorsal root ganglion for life, and it gets reactivated again and again. That is why a patient gets multiple episodes. The first episode has systemic symptoms like fever, malaise, body ache. In the subsequent episodes, we do not get systemic symptoms. In the first episodes, the lesions are multiple. They are severe, they are painful, they are extensive, and they take more time to heal. The lesions are vesicles on erythematous base, which form ulcer or erosion. In the first episode, they take 2 to 3 weeks to heal. In the next episode, they take 1 to 2 weeks to heal. Investigation has told Zank smear or confirmatory. Now, one problem that comes, many patients come to us with this report IgG and IgM of HSV1 and 2. These reports don't carry any significance other than differentiating the primary and the recurrent episode, or to differentiate between HSV1 and 2. They will remain positive for life, and patient needs reassurance for that. Now the treatment, we should remember primary episode acyclovir 400 mg 3 times a day for 7 to 10 days. In the recurrent episode, every episode only for 5 days. And if in immunocompromised patients, we need to give these drugs till all the lesions heal. If a patient is having more than 6 episodes per year, then we give suppressive therapy, acyclovir 400 mg twice daily. If more than 10 episodes per year, then we give 1 gram per day. This is to be given for 1 to 2 years. Now, one problem arises with pregnancy. If any female gets herpes in the primary episode in the second half of the pregnancy, or she has any prodromal symptoms or lesions at the time of delivery, then cesarean section is advised, because neonatal herpes is a life-threatening condition. Even if she has older infection, then at 36 weeks of gestation, we start suppressive therapy with acyclovir 400 mg 3 times a day, which has to be continued for 10 to 14 days after delivery. Now, and these are the commonest infections. It has been estimated 50% of the sexually active adults have some form of HPV infection. More than 30 serotypes can cause anogenital warts, out of which 2, 6 and 11, which are the commonest, but they are non-oncogenic. Oncogenics like 16, 18, 31, 33, 35 can also cause genital warts. They are usually asymptomatic, but they can block some outlet, and they are usually masses like this. We can see gray, pedunculated, cauliflower-like masses. Diagnosis is mainly clinical in this case. Now the treatment can be in 2 ways. Either we give something that patient applies at home, or we do something in the clinic. What they can apply at home is Imicomod cream. It has to be applied, a sachet has to be taken every time, a new sachet. Thin layer has to be applied at night. After 6 to 8 hours, it has to be washed with soap and water. Otherwise, patient will develop multiple ulcerations. It has to be done 3 times a week, preferably alternate days, maximum 16 weeks. If no response, then treatment failure. One cream that I found very useful is 5-fluorouracil 1%, applied for 6 to 8 hours, then washed off with soap and water. 6 to 8 weeks, we can give this. Next, something we can do in the clinic. The best treatment that I have personally found is podophyllin 20% resin. It has to be applied first, normal mucosa or skin has to be protected with white petroleum jelly. With cotton swab, we apply this resin over the lesion, and very strictly we tell patient after 4 to 6 hours, you have to wash it with soap and water. Otherwise, they will develop ulceration. Usually in 1 to 2 sittings, in 1 to 2 weeks interval, most of the warts subside. If they don't, we can go for surgical therapies like electrocautery, CO2 laser, chemical cautery, surgical excision. Now cesarean, earlier it was said the cesarean section must be done in case of anogenital warts. Now it is said that even if we do cesarean section, the child can develop infection. So it is not necessary unless it is obstructive from outlet or there is some chances of hemorrhage. Now molluscum, they are self-limiting. We get shiny yellow papules, asymptomatic, and they don't need treatment in case of immunocompetent individual. If immunocompromised or patient wants treatment, the best is surgical removal by curettage or laser. Topically, we can apply tretinoin or 10% potassium hydroxide. These are good options. Now syphilis, this was once considered the biggest STD of all time. In the primary syphilis, we get this hard, painless, indurated ulcer. In the secondary and tertiary, there are multiple symptoms. They are very difficult to explain right now. The causative organism, Treponema pallidum, incubation period is 9 to 19 days. Earlier, the early syphilis was 2 years. Now, CDC is saying only till first year is early syphilis. After 1 year, it is late syphilis, because the treatment varies because of that. Now, most of the patients that we are seeing today, they have not come to you for some symptoms of syphilis. They either want to go to Gulf countries or they donated their blood and they come to you with a positive VDRL report. Now, we don't know what to do. The VDRL, first of all, when we talk of VDRL, no lab is doing VDRL, they all are doing RPR. Okay, so that positive VDRL report doesn't carry any significance as such. You have to get a treponemal test like TPHA and VDRL with titers done. If TPHA is negative, patient doesn't have syphilis. If titers are below 1/8, 1/16, 1/32, 1/64, then patient needs treatment. If they are 1/2, 1/4, patient doesn't need treatment. It's usually biological false positive or old treated case. After treatment, within 6 to 12 months, the titers must fall 4 times. If initially they were 1/16, they should become 1/4. Otherwise, it's either treatment failure, reinfection, or patient is immunocompromised or has neurosyphilis. And TPHA and VDRL takes 1 to 2 years to become negative. And the treponemal test, they don't become negative usually throughout the life. Now the treatment, injection benzathine penicillin, 2.4 million units, 1.2 million unit in each buttock, deep IM. In early syphilis, 1 single dose. In late syphilis, 3 doses, 1 week apart. In children, 50,000 units per kg, maximum 2.4 million units. Now, if there is penicillin allergy, then we give doxycycline 100 mg BED for 14 days in early and 28 days in late syphilis. Other options are injections of ceftriaxone 1 to 2 gram IV or IM, 10 to 14 days, or erythromycin 2 gram stat, but they are under investigation. They are not recommended currently to be used in routine. Pregnant women, if pregnant women, even if she is allergic to penicillin, she has to be admitted and given penicillin after desensitization. Now, when we come to urethritis, we have mainly 2 types, gonococcal, non-gonococcal. The gonococcal main factor is that it comes in first week, non-gonococcal comes after 1 week, mainly 2 to 3 weeks. In gonococcal, we get thick purulent discharge, the above photos of gonococcal urethritis, thick pustular discharge. The symptoms are very severe pain, burning, micturition. In non-gonococcal, there is mild symptoms, and the discharge also you can see it's mucopurulent, it's not very irritating. The best investigation in this case is NAT. We can even use urine sample for that. The treatment, ideally, the dose has changed. Now ceftriaxone 500 mg IM, single dose for gonorrhea. And cefixime is now 800 mg single dose. Earlier it was 400. And ideally, ceftriaxone should be given, but if injectables cannot be given, then we give cefixime. Or for non-gonococcal, azithromycin 1 gram single dose, or doxycycline 100 mg BD for 7 days. If patient develops recurrent, male develop recurrent urethritis which is not responding, we should always consider trichomonas vaginalis, and metronidazole 400 mg 3 times a day for 1 week should be given. Now chancroid, in the patient develop multiple painful ulcers which bleed on touch. The gram stain helps in diagnosis. The cultures are gold standard but not available. The treatment is azithromycin 1 gram orally single dose. Now there are some STI I will discuss later. Now syndromes, why they are important. WHO and NACO, they promote syndromic approach to the management of STIs. They can combine a cluster of symptoms in which multiple organisms are implicated, and they treat the symptom as a syndrome so that multiple organisms can be treated, and the patient is treated at one visit, and we do not lose a diagnosis, and the spread of STIs is prevented. Now presenting in case of males or females, if they are in discharge, urethral or anorectal or cervical, or painful scrotal swelling. In both the cases, Neisseria gonorrhea and chlamydia are implicated. We give cefixime 800 mg and azithromycin 1 gram. Grey kit comes from the government for that. If there is ulcer can be genital, anal or oral. Then we divide into two parts. If vesicles were present, then acyclovir, because it is herpetic, 400 mg 3 times a day for 7 days. If there were no vesicles, then we have to ask for penicillin allergy. If it is there, then doxycycline 100 mg BD. If it is not there, then injection benzathine penicillin. This is for to take care of syphilis, and for hemophilus or chancroid, all ulcer cases have to be given azithromycin 1 gram stat. Inguinal swelling, we treat for both chancroid and LGV. For chancroid, we give azithromycin 1 gram stat and doxycycline 100 mg BD for 21 days for LGV. Now in female, if there is a discharge, speculum examination should be done and should be seen from where the discharge is coming. Is it coming from cervix or is it coming from vaginal wall? Again, like urethral discharge from cervix, if it is thick, purulent, then it is gonorrhea. And if it is mucopurulent and not so thick and cervix is not very inflamed, then it is non-gonococcal. The treatment remains the same, 800 mg cefixime for gonorrhea and 1 gram azithromycin for non-gonococcal. If it is coming from vaginal wall, then if it is homogeneous, grey and very foul smelling, it is bacterial vaginosis. We give metronidazole 400 mg twice a day for 7 days. If it is frothy green with punctate hemorrhages on cervix, which is known as strawberry cervix, is trichomonas, trinazole 2 gram single dose, and patient has itching with curdy white adherent discharge, then it is candida. We give fluconazole 150 mg stat. Now these measures are very important, which have to be followed in all cases of STDs. Privacy and confidentiality is the utmost importance. NMC says that all STI patients should be examined separately. There should be a separate room for the examination of all STI patients. We should provide them a comfortable environment. We should be non-judgmental and we should have professional attitude so that patient feels just like we are treating a sore throat or any other condition. Patient should not feel judged. Detailed history of sexual exposures. What kind of exposure? It was penovaginal, penoanal, how many partners, how many time exposure was done is very important. We have to take history of other symptoms and examine accordingly. For example, a patient may just complain of burning while micturition. That burning is because that patient is having an ulcer on another aspect of prepuce and patient is having chancroid, and we didn't examine the patient and we just treated for gonorrhea and sent. So that is why history and examination is very important. All patients should be examined from umbilicus to knee, including per vaginal and per rectal examination. Patients should be counseled regarding spread of STIs, risk factors, and how to prevent. We have to clear any myths and doubts they have. Then there is ABC of preventing STIs, abstinence from further exposure till treatment is completed. Being faithful to one partner, consistent means on every exposure and correct use of condoms. We have to demonstrate if required, if patient doesn't know. Then all patients should undergo HIV 1 and 2 ELISA, VDRL, HBsAg and anti-HCV testing. And they should be called back after 1 week, first to get the test report and see if the symptoms have subsided. If they have not subsided, then they should be ideally referred to a higher center or specialist. All contacts in last 3 months, because syphilis has period of 3 months, LGV has period of 3 months, some STIs have lesser period, but we assume that these patients have exposure to multiple infections, so last 3 months all the contacts should be examined and treated. These are some less common STIs. LGV, we get inguinal bubo, painful swelling, and treatment is doxycycline and MBBS for 21 days. Donovanosis, we get beefy ulcers, and azithromycin 1 gram only once a week or 500 mg daily for 3 weeks, or doxycycline 100 mg BD for 3 weeks. Scabies, many people think that scabies is just a normal infection. It's a very common sexually transmitted disease. And in case of scabies, we get thick, itchy nodules, very itchy nodules over the genitalia. But there's another thing known as pediculosis pubis, in which we don't get nodules. We get this brownish hemorrhagic macules and prickly itching over hair-bearing areas, because this thyrus pubis needs hair to stick to it. And the treatment is permethrin 5% in case of scabies, but in case of pediculosis, it's 1%. In case of pediculosis, we should always ask them to shave off or cut the hairs. And clothes and beddings have to be washed in both the cases. But in case of pediculosis, all the clothes and beddings after being washed should be kept in a Ziploc bag for 2 weeks. Then they should be reused. Thank you.
Yes, sir.
Yes, sir.
Mike.
Yes.
Hello.
Has no role.
No, I said that if the treatment failure is there, then we have to consider patient has
Even then,
neurosyphilis, we don't give doxycycline.
you put in the bracket, that is a thing.
Okay, sir.
Yeah, treatment is entirely, even penicillin is not indicated. So one thing, another thing is, VDRL titer, both speakers, less than 8 dilution, insignificant.
Yes.
It is not so. Suppose
less than 8 dilution doesn't need treatment at that point of time.
No, sir. I am totally disagree. Suppose primary syphilis, we are seeing the case after just 1 week after this case. It will be 2 dilution, 4 dilution.
No, sir. That I was talking about the patient who just come with report and don't have any symptoms. I was talking about those patients.
Sometimes even it may be really maybe in the low dilution. We have to confirm it with the troponin, that is a troponin test, and sometimes low dilution also we cannot rule out. Usually biological false positive will be less than 8. So that is the thing, but it is not, does not rule out totally it is not syphilis. That is other things. Excellent. Thank you.
Whether penicillin is available now? Free?
Yes, sir. Injection penicillin we give regularly.
What about crystalline?
Propane
Crystalline penicillin is available? Yes. Okay. But medical, if you are prescribing to medical shop, they are not. Out of stock.
We administer it in the institution only. The problem with penicillin is that reaction rate is very high, so patient should ideally be, even if for benzathine penicillin, we admit the patient in daycare.
Yeah.
And then we give benzathine penicillin, and ideally we give Avil and dexamethasone also before that, and then we ask patient to wait for 4 hours before we ask patient to go. And we keep the patient in emergency till that time, because it can cause severe reaction at any point of time in 4 to 6 hours.
Thank you, Dr. Ajitesh Prakash. Excellent presentation, as Dr. Murugan sir had said. we have, if anyone having more questions, we can take it during the lunch time. And we'll move on the next session. And before moving the next sessions, we'd like to felicitate you. So I request Dr. Sarath Kumar ji, I request him to come and felicitate.
I'll just request Dr. Paritosh Tiwari sir to please come and felicitate Dr. Ajitesh. Please bring the memento. And Dr. Paras sir, please, and Dr. Ajan sir, please accompany with, please felicitate Dr. Ajitesh. And for the next talk, Dr. Sarath is also here for a very interesting topic.